Hey, today is a really, really special treat for me, so I know you're going to love it. But I'm with Dr. Biju
Biju.
Biju Krishnar.
Krishnan. Biju
Krishnan.
Krishnan.
Biju
That's
Krishnan.
it. You got it.
And Krishna is a god, a
Yes.
Hindu god.
Hindu god, indeed.
And you kind of are a short-term ortho god, so maybe you should change your name to Dr. Biju Krishna.
Maybe that's something to think about.
But Dr. Krishna, amazing. Born in India,
Yep.
but at age 2 moved to Scotland,
That's right.
and then lived in Scotland until you were 45,
Yeah, I suppose so, yes.
and then you moved where we're at today, which is Singapore.
Yeah, so welcome to my new hometown, which is Singapore. I was going to say sunny Singapore, but it's not particularly.
I find
Sunny
that
today.
very very cool that you've moved twice because the research I see from The Economist is that less than 1% of Earthlings live in a country they weren't born in. So 99% of people live in the same country they were born in, and you actually left India, went to Scotland for 45 years,
Sure.
and now you're in your third country. I'd love to see the stats on what percent are living in a third country. I bet it's 1/10 of 1%.
I have no idea, but certainly the first move wasn't my choice.
Yeah,
The
Mom and Dad did that.
That was that. Yeah, the second move certainly was my choice. And
Yeah.
do you know, I just wish I'd done that a lot longer, earlier. You know, maybe 5, 10 years ago. I'd have loved to have had the opportunity. I see my children now. My children have lived in the UK and now in Singapore, and they're especially in Singapore, where there's such a melting pot of different cultures and communities and people. They get a really wide view of the world that they never would have got living
In Singapore?
So in Singapore, it's amazing. It's a real melting pot here.
And you think it's more melting pot than Scotland?
Scotland is Scottish, you know.
Okay, so Scotland is not like London.
Very not so. No.
Because don't you think London's awfully melting?
London is very much like that? Yes.
Yeah.
So I mean, Singapore is pretty much like London in that sense, probably about the same size as well.
Yeah.
So you have of course, you're a very Southeast Asian culture, so it's completely different to that Western attitude and outlook. So yeah, they've got a great experience. But saying that, a lot of the people that they're associating with are, you know, Australians, Americans, Europeans, Chinese, Japanese. So they get a great range of different views and cultures and attitudes, and that can only be good, I think.
But I think Scotland has got one of the greatest cultures of all time. That was the birthplace of Adam Smith,
Indeed.
the first economist.
Yep. Mm-hmm.
And he wrote his book, The Wealth of Nations,
That's
in
right.
1776, which was so weird because he was a 32-year-old Scot.
All right.
The same year, 1776, another 32-year-old Scot, Thomas Jefferson, wrote basically the Declaration of Independence, Free People. And the American experience was really the first time free people collided with free markets.
All right. Okay.
And that was a
That
game
is
changer.
interesting, yeah.
Because all throughout history, sometimes there's been free people, sometimes with democracy. I mean, there's democracy going back to, Plato's Republic,
Yeah.
the Roman Empire. But you really didn't have free people and free markets until two 32-year-old Scots. But my favorite Scottish joke is that's how wire was invented, when two Scots were fighting over a penny.
Yeah, that's probably some truth in that, actually.
So Dr. Krishnan is internationally renowned as the creator of one of the world's most popular adult cosmetic orthodontic systems, CFAST, which stands for Cosmetically Focused Adult Straight Teeth. He's qualified from Dundee University, Scotland, and his practice has been highly commended as best specialist practice in Scotland and voted best private practice in East Scotland. Dr. Krishnan was also recognized as one of Scotland's outstanding dentists. Biju lectures extensively, nationally and internationally, primarily on cosmetically focused orthodontics, in which he has pioneered revolutionary new concepts using the CFAST adult brace systems, which he personally developed. CFAST was successfully launched in the USA and the UK in 2011 and is now one of the world's largest providers of cosmetic orthodontics, which is with a presence in Europe, Scandinavia, Southeast Asia, and Australia. Dr. Krishnan has published in many journals internationally and recently authored the first book on cosmetic orthodontics. He is on the board of the British Academy of Restorative Dentistry and the editorial board of Aesthetic Dentistry Today. And today we're talking cosmetic orthodontics. My question is, What made you start a new one? Considering, there's fixed braces and wires that
Sure.
goes all the way back to the Egyptians, and then there's a lot of clear aligners. There was
Yeah.
Invisalign, there was Clear Choice. No, Clear Choice was the Clear Connect. Clear Connect. What made you want to start another? Is that the genre you put
Yeah,
in?
yeah, yeah. So it's a good
Clear
question.
aligners.
So we're not really aligners, but so let me give you a little bit of background. I think as with all inventions, they say necessity is the mother of all invention. I'm a general practitioner, and for many years now, I've been very interested in minimally invasive cosmetic dentistry. The idea of just picking up the drill and starting cutting didn't fit well with me. So the idea always was to try and move the teeth into a better position prior to then doing some restorative work. I got a lot of patients that used to come to me for veneers. They wanted a quick result, and I never found it great to just pick up the drill and start cutting. So we looked at different systems that allowed us to move the teeth. I mean, going back even one step, we used to refer a lot of those patients to the orthodontist to try and get those teeth into a better position. And the question I'd always have for my orthodontic colleagues was, this patient is unhappy about a mild crowding of the upper lateral incisor. Can you correct that? And the orthodontist said, yeah, sure, I can correct that. And I said, great. How long is that going to take? 18 months. Was it really? For a lateral incisor? And they said, yeah, well, they've got problems at the back, they've got class 2, and they're, all these sort of issues. And I think, well, the patient's 45, they're not really interested in that, they've survived. The chances are they're going to survive a little bit longer with that crossbite. Can you not just fix that lateral? Yeah, but we've got to treat all this other stuff. So I'm thinking there's going to be a more pragmatic approach, because quite frankly, if you don't do that and move that tooth, all that's left for me is to cut that tooth. And I quite frankly don't want to do that. So, as you well know, about 10, 12 years ago, aligners came onto the market. And that's great, because it really empowered general practitioners to do orthodontics. But the problem, again, that I had when I did aligners was it really was orthodontics in the true sense of the word. And, I'm a general practitioner. I have no real interest in orthodontics. I have an interest in cosmetic dentistry. So it was quite a roundabout way for me to provide good cosmetic dentistry. Other systems then came on the market that started to introduce the concept of a fixed wire or a fixed appliance, brackets and wires. But again, the problem I had with those systems were all of those were really developed by orthodontists for use by general practitioners to do cosmetic dentistry. And the orthodontic component always got in the way. I was ending up with problems with the bite. And I was doing things certainly that I felt I didn't need to do for the vast majority of patients coming to see me. So really the idea was then to develop a system that was really met my needs in terms of, well, look, I just want to focus on the front 6 teeth. That's what the majority of patients come in for. Let's just develop systems that can do that. And if I had a blank sheet of paper and an ideal wish list, what would this system look like? And that's what I think we've done with CFAST. And over the past 5 or 6 years, it's changed a lot. I think we've been the one system that's just constantly been innovative and looked at the modern technology and tried to introduce some of the advances that we have in technology into our system. So you look at what we have now, and I think we're so far ahead of pretty much everyone else out there, certainly in terms of cosmetic orthodontics. So that's not to be confused with not comprehensive orthodontics. This is not a replacement for comprehensive orthodontics. That's a completely different animal. What we're trying to do here is give people a cosmetic smile, a nice smile, really using a fixed appliance as an adjunct to other restorative treatment. So most patients, when they come to see me, when they want a nicer smile, the first thing we'll think about doing is aligning the teeth, getting the teeth into a better position. The next thing we'll do is do a bit of tooth whitening. And then if we need to do a bit of adjustment, a lot of patients present with incisal edge wear, we can do some bonding or we can do some veneers. But by this time, it's minimally invasive. So that's really a sort of a potted history of where we are today.
So how does a dentist do this case? And by the way, I understand. I feel your pain with the orthodontist. It seems like if your only tool is a hammer, everything looks like a nail. And if you ever send anybody to an orthodontist, it's and I was surprised you said 18 months. Mm-hmm. Because in Phoenix, you send anybody to an orthodontist, it's minimum 24 months. It's 24 to 30 months. It's $6,000. They need to put 1/3 down. It's just like, okay. So it's and the other thing is not only is it one size fits all, I look at so many of those cases, like how many of those bicuspid extraction cases where they just needed, 3 or 4 millimeters, if you would have took out the MOD
Sure.
amalgams and
Sure.
put in MOD composites with,
Sure.
it just seems like there just could have been, you can't really go to a market with one car.
Sure. I mean, this system, I'm not really putting down what orthodontists do. So what
Correct.
they do is it's a hugely specialized skill, and there's a reason they train so hard and so long after their degree to do what they do. This is not really an alternative to orthodontics. This is really an alternative to invasive crown and bridge work. Think of it like that.
Right. So how does it work then?
So we have the majority of cases that we see are treated with a fixed labial appliance. So it pretty much looks like an orthodontic appliance, but the brackets are positioned such that all the movement is kept to the anterior region, and we just really minimize any movements in the bicuspid area.
So these are brackets with a wire. It's not a retainer.
It's brackets with the wire. It's not an aligner.
It's not an aligner.
No.
By the way, what's the big aligner out of the United Kingdom?
Well, I think the big aligner everywhere is Invisalign.
Well, no, there's another. What's the other one out of
We have Smile True in UK, and we have Clear Align. I think we have
TIFF.
So TIFF. TIFF did a great. TIFF's a pioneer when it comes to cosmetic orthodontics, and TIFF and his colleagues worked with Inman Aligner.
Inman aligner.
Yeah. So, and that's originally
That's
from the
a
US.
retainer.
That's a removable appliance. Yes.
So this is not a removable appliance.
Not a removable
So
appliance.
it's really not an aligner, or it's not a what is the genre? You're calling it a liner, or
I'm
I'd
going
say
to, it is. It looks like
Clear-
a fixed. It's a fixed brace.
it's fixed braces because
brace.
the I think of Invisalign and Clear Connect and Inman aligner as what do you
So
put
Clear
those under?
Connect and Invisalign, those are aligners. Those are sequential clear trays that move the teeth incrementally. Inman's very different. Inman is a removable appliance that, again, really just focuses on the front, mainly the incisors, and pushes those teeth into a nicer sort of position. I think the main issue with Inman, it's a little bit restricted in terms of what you can do. You can do much more with a fixed appliance than you can with a removable appliance. Some patients can find it a little bit bulky because it covers the palate, so it affects the speech. But when it comes to moving teeth, really a fixed appliance is the gold standard. So we incorporate all the advantages of a fixed appliance, but as much as possible we try and remove the orthodontic element from it.
Walk into a case what it would be like.
So we have when a case comes in, first of all, the patient's assessed. Now we have a triage system in place, so we ask the dentist to take some photographs and send it to one of the orthodontists or one of the mentors that they have. We have a one-to-one mentoring support system in place, which is really important, which we'll talk about later. It's one of the reasons I'm here in Singapore, in fact. So they take the photographs, they submit it to the lab or one of the orthodontists or one of the mentors. That case is then assessed for suitability. If the case is suitable, then they either take a 3D scan of the mouth, or they take some PVS impressions, send it to the lab. The lab then construct the appliance. It's all made digitally, and send it back to the dentist. And it's in an indirect carrier system. So the dentist doesn't have to worry about where the brackets go. It's all pre-positioned for them. And we use an indirect bonding system to, a bit like a gum shield. It goes on the teeth. The dentist just cure the brackets in place and just peel the carrier away. So all the brackets are perfectly positioned.
That's a nice, fast way to do it.
It is great. And one of the
I
biggest
know orthodontists who I know a lot of orthodontists. Derek Mahoney's one who does that, and
Yeah.
he's cut his banding time down,
Yeah.
to a fraction.
I've done a bit of work with Derek, and Derek helps with this. Helps us with some of the CFAST courses. So I've worked
Derek
with-
Mahoney does.
Yeah, in fact, Derek actually wrote the foreword to my book.
Really?
Yeah, so and I know you know Derek very well because the last time I was in Sydney, I think you came up in conversation a few times. So
Yeah, and
Yeah.
last time we were there, my brother moved to Sydney,
that's
Australia.
right. That's right. You
And
mentioned that.
I've lectured there probably every 3 or 4
Yeah,
years
yeah,
for 25 years.
No, Derek mentioned that, so I know you know Derek quite well.
But I miss my move to Australia because I always said you could only move there till 50.
All right. Okay.
And when I first learned that, I was about 43, and every time I ever went to Australia, I always think this is the only place I ever go all the time. That when I come back to Phoenix, I'm always saying, why did I come back to Phoenix?
Yeah.
Then my brother had the brains to move there permanently.
Yeah.
But when he moved there permanently, I was already 51.
It's a big move.
Yeah.
Australia's a big move, isn't it?
But you know what? I swear it's just a greater civilization.
Really? Yeah. I mean, I love Australia. I certainly love
Oh
Sydney.
my God!
And,
I mean, the suburban life
Yeah.
in Phoenix is so boring. I could walk out my street, fall asleep for 3 days, and no one would know it. My brother, you walk out his front door, and it's a restaurant, then a bar, then a bookshop, then a book. You know, it's just so exciting. You don't need a car.
Sure.
My brother doesn't have a car.
Right. Okay.
Yeah.
It's a bit like Singapore then.
Yeah.
As you'll no doubt find out tonight, we'll show you a bit of the town.
So you moved here from Scotland to set up the CFAST in Singapore.
Really just set up CFAST in Southeast Asia. So,
And when you say Southeast Asia, what does all that include?
so we're talking about Singapore, Malaysia, Philippines, Thailand, Hong Kong. We've not quite ventured into mainland China yet, and we're looking at very soon Taiwan, Korea, these sort of places.
Wow, you have big expansion plans.
Absolutely. That's the
So
only
so how's it taking off in
It's been amazing in Singapore so far. You know, in the last year, I mean, last year was a crazy year for us. You know, we shifted the whole family, and we had the whole idea of settling into the house. I'm working in general practice still, getting kids into school, setting up our offices, and then in between all that, we trained over 100 dentists here in Singapore.
and how old are your kids?
We've got quite a range, so from 17 through to 12, and then 4.
So are they excited or are they mad at dad?
They love it.
They
They
love
love it. I think initially with kids they don't like change too much, but certainly now they're here, I think they love it.
Well, it's definitely totally different weather
Oh.
than Scotland. They gotta love the equator over Scotland. You know, I find beauty so arbitrarily. So I mean, I think of straighter teeth as easier to brush and clean
Sure.
and all that stuff. But there's a lot of people who say that you really can't tie it to less gum disease, less decay. You know, there are some research people who say that it's just all cosmetic. But what I think is funny in cosmetic is when you go to the United States, which is half the population is European Caucasian.
Sure.
They're sticking Botox and derma fillers, trying to puff out their lips. And then you come to Asia, where they draw a line from the nose to the chin, and if that upper lip sticks out in front of that, what do they call that line?
Yes,
They want that lip back.
Sure.
And it's funny because they'll spend a lot of money moving that lip back.
Yeah.
In the United States, they're all pumping up everything,
That's very
trying
true.
to move that lip forward. So I got to ask you, where's the beautiful lip? Is it on the line? Is it in front of the line? Is it behind the line, from the nose to the chin?
It really depends on you as a patient how you view it.
Yeah, it's
You know,
because
it's so subjective. You
yeah,
can't
it
really
is.
impose your view of beauty on someone else.
Yeah.
You know, so I don't try to do that. What we try and do is we try and find out where the patient
Do
is.
you know what I'm talking about on
Sure,
the Asian?
absolutely, yes,
Explain
absolutely,
that
yes.
because the
The
aesthetic
aesthetic,
line.
yeah.
Explain that because the United States is only 6% Asian, and so only half of those would be women.
Yep.
And only maybe a fraction of them would have the lip.
Yeah.
But a lot of these guys you're talking to are not really familiar. So review that
So,
again.
so if you look at that, if you take a line from the tip of the nose to the chin, basically the upper lip should just, or the lips should just touch that line. And anything forward of that line is seen to be anesthetic, and anything too far behind of that line is as anesthetic. But it's an interesting point that you brought up, because this has been a learning curve for me when it's come to treating teeth in Asia. Because in the West, when somebody says, I want straight teeth, what they mean is, my teeth are a little bit crowded. I want them aligned so that they're nice and evenly spread out. Here in Asia, when somebody says, I want straight teeth, quite often what they're saying is, I want my teeth less proclined. I want them back, so they're not sticking out. And that's caught me out a little bit in the early days, because sometimes teeth can be very straight, but they're proclined. That's not a look that people like here.
How do you bring the teeth back?
Well, you can't with cosmetic orthodontics. That requires orthodontics.
Is that by cosmetic extraction?
Or surgery. But yeah, so here you get a lot of what we call bimax, proclination, protrusion, and some of those cases probably have to be treated with extraction.
And I was lecturing the other day, and this little girl was telling me how she wanted to save up and she wanted to do that, and I'm just looking at this little girl's like, You're adorable.
Yeah,
You're
yeah.
cute.
Yeah,
Who
absolutely.
why the hell is this demon in your head?
Well, we have a lot of those conversations.
Yeah.
Yeah,
It's
believe
like,
me.
my God, you couldn't be more cute and adorable.
Yeah.
And
I think those are your biggest. Those are always my biggest challenges. The patients that start good. Those are the ones with the high expectations, which you're just never going to meet. So those are the ones you just don't treat. I don't treat anyway.
so I interrupt you. So walk these guys through a case.
So again, so a patient comes in, you're taking impression, you send it to the lab. The lab will send you back the appliance. Just a little aside here, CFAS is not just about a fixed labial appliance. We also have lingual appliances, and we also do aligners, because some cases there's a bit of a bit of flexibility in terms of the clinical case. Some clinical cases require an aligner. Some require other ways of treating the dental conditions. So we don't restrict ourselves to one specific appliance. But the main appliance that we use is a fixed labial appliance. So the dentist then puts the appliance on. Very straightforward. It's an indirect bonding technique. And then the wire is attached. Now, one thing that we have with CFAST, which as far as I know, no other system has, it's a patented self-ligating bracket, which means that there's no modules, no ligatures. You just pop open the bracket, little door, put the wire in, and close.
No rubber bands.
So simple. No rubber bands. Doesn't stain. And that's one of the big things moving to Asia. If you tell somebody in this country, don't eat curries, because it'll stain your bands, they come back with, well, what do I eat? It's very restrictive to have those rubber bands in place. So we don't have that anymore. And these brackets are, I talked earlier about using real technology, some of the advances. These brackets are all 3D printed. So they're super small, very low profile, extremely aesthetic.
Now, are you making your own bracket and wires? Or
Yeah, so these are all supplied by our partners in the US. So these are super brackets. I mean, if I was wearing it now, you'd have difficulty telling I was wearing it.
And why is Lingual still so a minority? What percent of your cases in CFAST are done Lingual?
About 5 to 10. You're right.
For you personally, or
Yes.
for the company?
No, I think for the company it's probably 5%.
Yeah. What is? Well, I mean, if everyone's doing all the Invisalign
Sure.
and Clear Connect and all this stuff to avoid braces, and you can just put them on the inside, why is that just not
I
seen?
think there's several places. I mean, we advertise lingual braces a lot, and a lot of people come in for lingual braces. I think dentists have a reticence in providing lingual because it is more complicated than a labial appliance. It's a bit more demanding in terms of just physically fitting appliance and adjusting it. It's also more expensive in terms of lab fees. So what happens when a patient comes to see me? They come to see me because they want a lingual appliance. They don't want to wear an appliance that is visible at all. But when I show them how aesthetic the labial appliance is, and the fact that they can probably finish their treatment in around about 4 to 5 months, and it's going to cost them significantly less than the lingual appliance, most patients, even though they came in for lingual, are happy to go with labial. I mean, these labial appliances are super cosmetic. And most patients say, well, yeah, I'm saving a few $1,000s. You know what? I can live with the labial for a few months.
On our iPhone, the Dental Town app started the online CE, and we put up 350 courses, and they've been viewed 500,000 times.
What is that?
Have you ever thought about making an online?
We have an online course. In fact, we have what we call a CFAS University, which is very much online. So everything that we teach, not just in terms of orthodontics, but a lot of the adjunct courses as well, in terms of things like bonding, composite bonding, minimal prep veneers, occlusion.
And that's on the website cfast.com.
So we have a CFAS University. It's a separate website. If you go to cfastresults.com, that's the main website.
And
now,
the CFAST is for cosmetically focused adult straight teeth.
Yeah.
So if you go to cfastresults.com,
Sure.
that's where you have
So in the cfastresults.com, there's two parts to that website. The first part is
You just pulled up right here, right?
it's a public-facing website, and on this part of the system as well, you can log in and you can see. It says here, "I'm a dentist." That allows you to log into the professional side. So this logs into the dentist part of the website, which on there they can access all the modules, the downloads, everything basically. It's like the whole course online.
So if someone goes to cfastresults.com, how many hours of instruction are there?
Well, on the CFASresults.com website, that's really a support website. So we have on there the whole course, basically. So you're talking, oh God, many hours worth of downloads, videos, how-to videos. Actually, the whole course is on there as well. But separate to this, we actually have a separate system called CFS University, which has a whole bunch of other stuff on there, which goes into much more depth. So it has the whole course online. So if you're familiar with things like fixed appliances, I've done other short-term ortho systems. Then
I think I'm having a hard time with the word appliance because in my walnut brain in the United States, born in Kansas, an appliance is something made at a lab.
Right. Okay.
But if you're brackets and wires.
What do you call that?
Fixed.
A fixed brace.
Yeah, we just call it fixed.
Fixed. Okay, it's a fixed. So if you've got a fixed.
So fixed brackets and wire.
Yeah, fixed brackets and wires. If you're familiar with doing that, if you have experience in doing that, then we have an online conversion course. So it walks you through the system. It's in 5 separate modules, total about 8 to 10 hours worth of downloads there. And it allows you to go through the system and become accredited to use it. Over and above that, we have a lot of other lectures that come in.
So where's your lab that makes the...
So we have several labs. We have one in the US, in Texas.
That was Skip Pruitt.
Yeah, Skip Truitt's.
Skip Truitt. That was his the Skip Truitt, the guy who did all the ortho, or is his son?
Yeah, no, Skip Truitt is the guy that's very famous for the ortho. I think Skip has trained over 50,000 dentists in orthodontics.
Yeah, so it's his lab.
Years. Yeah.
Now, how old is he? Is he still out there lecturing? Or?
Skip, yeah, we just met him a few weeks ago, so he must be in his, if I get this wrong, he'll kill me. I think late 60s, probably 70s by now. But still looking very, very good for it.
In Dallas?
In Dallas.
Oh my God! I think I studied from him in like '87.
Yeah.
So how old do you think he is?
So he must be in his late 60s, early 70s, and he's still going really
There's
strong.
no way he could be in his late 60s. He has to be in his 70s.
He must be in his 70s. I'm just erring on the side of caution.
He just don't want to get in trouble. So Skip's still out there lecturing.
Skip, as we speak, he's just on his way to Malaysia, so he's not far from here. He's in KL, Kuala Lumpur now.
Is he in another orthodontic? Is it just lecturing for his own?
So Skip really talks about proper comprehensive orthodontics. So we're talking more orthopedic type orthodontics. He talks a lot about non-extraction and developing the arches.
So you're using his lab.
So you use his lab.
What's his lab called?
It's called Triple O.
It's called what?
Triple O.
Triple O?
Yeah.
TRIPLE.
O.
Just O.
Triple O, yeah.
TripleO.com?
It must be tripleo.com, yeah.
Or TripleOLab.com?
I'm not sure. I think it's tripleo.com.
Okay, and where are your other labs? Singapore?
So we have a lab in Singapore. We have a lab in Birmingham in UK. That's also one of the Triple O labs. So that's
Skip Truitt's lab?
Yep, in England. Well, it's one of Skip's business partners, who also actually has a stake in our CFAST business as well.
Really? Does Skip have a stake in that?
In the US lab, yes.
But not in CFAST, though?
Not CFAST, no.
But the Triple O lab guy has a stake in.
Yes, absolutely.
So where are all the Triple O labs?
There's one in US and there's one in
Dallas and Birmingham.
In Birmingham, in England, yes. And we've also have a lab here in Singapore and another lab in Australia.
Where in Australia?
But these are specific CFAST labs.
Yeah.
The one in Australia is in Sydney.
And is that with Derek?
No.
But that's where Derek is.
Derek's based in Sydney, yes.
Yeah, Derek, one of the reasons I'm such a huge fan of Derek Mahoney is he is the epitome of what everybody's been telling orthodontists for 20 years, that he helps all the local general dentists with any of their ortho cases.
That's right, yeah.
And what it turns out to do is they'll do about 5% of their cases, but then Derek will get the 95% of all the referrals.
Sure.
And everywhere else, because Derek sees the end in mind, the end vision in mind, which is the patient, and he thinks in abundancy. and most orthodontists around the world think in total fear and scarcity. And if you ask them a question, they're not going to help you at all.
Yeah.
And,
No, it's very refreshing speaking to Derek. You know, he really understands the bigger picture. And
what does he have? 4 offices in
yeah,
Sydney
I mean, Derek
and a
is
half
just
dozen.
hugely
And how many,
successful.
how many orthodontists in each one of
Oh,
those?
I mean, I know he has a internship program, so I think part of his course he allows the people on that course to come in and work with his practice. So it's a real hands-on.
I've never seen
element
anything like it.
No, it's amazing. He really is
Yeah.
an amazing guy.
Yeah.
Yeah, very
Just,
impressive.
incredibly impressive.
Very impressive. And he does a lot of work in the US. He's coming more and more and talking in the US. So, yeah, if any of your listeners get a chance just to go on one of Derek's courses, strongly recommend it.
It's just tough because from LA to Sydney is a 15-hour flight.
Yeah, but he runs. I think he runs courses in the US or will be
Yeah,
very
in
soon.
LA. But once you get to LA, it's another 5 hours to New York.
Yeah, I know. I've been there. I've done that. I know what that feels like.
Oh my God! You get off the plane from Australia, and you know. I remember the first time I went there. It was before cell phones,
Sure.
and I walked out the plane. And I went to the cell phone to call
Yeah.
my ex to get a ride home, and I couldn't even remember my number. I was just sitting there like, oh my God, I can't even remember your brain's just fried. So you feel CFAST is a unique enough selling proposition to carve its own space in this market?
Well, it has done. You know, and
It's exploded in the UK.
yeah, exploded in the UK, Australia, and here. You know, since the year that I've been here, we've trained over 100 dentists, and it's just growing every month on month.
So what do you think it really had that Invisalign didn't have, or why or?
Well, I'll tell you what, because it's not orthodontics. You know, general practitioners get it because it really is quite simple. We're dealing with the things that patients come in for requesting. You know, I want nice smile. I want straight front teeth. It just deals with that. It doesn't deal with any of the complexities of orthodontics. It's a simple system, so dentists just get it. You know, it's nothing overly complicated. But the reason I think that it has really exploded is because we provide very, very good one-to-one support. It's that kind of support that Derek Mahoney gives. You know, the reason I've sold my practice in the UK and moved out to Asia was because I know that I need to be here. I need to be on hand. I need to be able to speak with those dentists, look them in the eye, and say, "Hey, you got any problems? Speak to me. You know, I'm here to help." And that's why we do that everywhere we've been.
So you set up a CFAST lab in Singapore?
Yep.
It wasn't a triple O lab? It was
No, well, we do it in conjunction with a lab that was already here.
Now, are you going to set up a dental office?
No,
For you?
I work in practice here, but I'm too busy really with CFAS to set up my own practice here.
So you're working with someone else?
I work with someone else.
So was it hard to get a license as a UK dentist?
As a
Getting
UK
license in
dentist,
Singapore?
the degree is transferable.
Because Singapore was a British colony?
I think yes, yeah.
And
very much so.
Hong Kong?
Hong Kong as well, yeah. So
And Australia?
Australia.
And the United States? And India? You've only lived in countries that were...
I mean, if you're talking history, then I think there has been no empire bigger than the British Empire ever in the history of empires.
It was 68 countries.
That's right. You know, so
Yeah.
most of the globe was British at one point.
So the it was very easy to get a license.
Yeah, so I mean, we have to come over here, and there's a 2 years where we do a conditional registration period where I have to work closely with one of the other dentists to make sure I understand the local nuances in providing dentistry, and that's fine. And after that, it's you can get your full registration.
So what do the locals think of the local dentists think of a new guy coming to town? Do they look at it as fear and scarcity, like, hey, we don't want any outsiders coming into our deal? Was it open arms? What,
Do you know,
what
hey,
was that like?
I think I've been really lucky. All the guys that I've met have been hugely welcoming. Do you know, we come here with an idea to teach and to educate and look at the other possibilities that are available out there. And I mean, so far, the reception I've had has been hugely positive. You know, we've trained a lot of people. We've helped a lot of people develop their cosmetic dentistry skills. And you know, Singapore's there's plenty of patients. There's no shortage of work. So certainly,
But you've practiced in two very different models, because the United Kingdom Scotland is very insurance driven with the NIH and the
NHS,
government,
yeah, sure.
the NHS.
Yes, that's right.
The government's very involved in dental.
Sure.
And Singapore's kind
Almost
of
completely opposite. Yeah.
That's I mean, when I remember explaining to dentists in China about dental insurance, and they're like, "Well, why would your government or your boss?"
Sure.
I mean, you're the one drinking Dr. Pepper, and
Yeah.
you don't brush and you don't floss, and the Chinese dentists are looking at me like, Well, why would
exactly?
why would someone
they pay
else?
for your problems?
Yeah.
that you created.
Yeah. So tell me, what are your thoughts on that? I mean, what does that make you think of the NHS system, or like in America? I'd say 95% of dentists just say, well, if the insurance isn't going to pay, that's like that's the end.
What?
And now you're in Asia where they don't
Yeah.
even know what dental insurance is.
Sure. So we have. I was fortunate in the UK. I had two practices. One practice was very much NHS based. The second was more of a specialist cosmetic restorative practice, which is purely private. So I got to see a bit of both worlds in the UK. Very much what's happening in NHS dentistry is because it's so cheap for the patients. The patients don't really value the skill of the dentist or the quality of the work that they're getting. So dentistry in the UK, on the whole, is hugely undervalued by the patients. And the profession is undervalued as a whole by the patients and also by the government. And right now there's a whole bunch of problems it's kicking off there because of that. So, but what's happening now, certainly with UK dentistry, is there's a lot of stuff that, especially when you come to the cosmetic side, that isn't available on the NHS. So when it comes to those more cosmetic type treatments, patients are starting to understand the real value of good dentistry. But at a basic level, when it comes to prevention and simple fillings and stuff, really dentistry as a whole is hugely undervalued because it's so cheap. How can something that's that cheap be of value? So I feel that, and a lot of dentists feel that they're not valued, their profession isn't valued, their skills aren't valued, both by the patients and by the government. That's a sad state of affairs.
So would you say that the dental economy in Singapore and Hong Kong is healthier than in London because it doesn't have this government interference with insurance?
Having the government subsidy in one sense is a wonderful thing because you will always be treated. There's always the concept for NHS dentistry was if you need the concept with NHS medical or dental treatment is that if you need help, you will get it. It's free at the point of delivery, and that's a wonderful thing to aspire to. But it's a rod for the political, a rod for the government at the moment in the UK. Here, of course, because it is so expensive when you compare it to other things, people look after their teeth, so they try not to get into a situation where they need dentistry. Saying that, the interesting thing I found is that I find tooth decay is less here, but perio is worse. Okay, so you talked earlier about what straightening teeth for periodontics. Does that work? Yeah, it really works. I can show you lots of slides that show you that.
Okay, well, there's something I don't know if it's if people are afraid to talk about it because it's race related, but I read once back in the day in the 80s that there's basically that the Asian tooth has a very constrictive cervical neck, and because of that constrictive cervical neck, minerals like calcium and phosphorus precipitate out and form tartar calculus easier, and thus make it easier for gum disease. The opposite of that is the Africans with the most bulbous tooth. And if you talk to any pediatric dentist, they say, yeah, keeping a chrome steel crown on a little baby African tooth, there's no undercuts. It's hard to keep on. And that the Caucasian, or we used to teach the Caucasoid, was in the middle. But do you think the constrictive cervical neck has anything to do with it, or do you think it's something else?
I can't tell you the clinical thing because I can only tell you what I see anecdotally every day. And what I see is that people in Asia are much more susceptible to gum disease and periodontitis than their counterparts in the West. Now, I can't tell you.
Their smoking is off the charts.
There's that as well.
I mean, when I was in Malaysia, I mean, you almost didn't see anybody without a cigarette in their hand.
Sure, but I see a lot of patients who don't smoke at all, but still have and have relatively. I'm not saying they have poor oral hygiene. They have average oral hygiene, but they have a lot of perio that you wouldn't necessarily associate with that level of hygiene. So so
you see less decay in Singapore.
I see less decay
than in Scotland.
Yeah. Oh, Scotland, we have rampant decay.
So why does Scotland have rampant decay?
Again, I think it's a case of poor education. Messages not getting through. It's just not really changed significantly over the years.
But I thought you said something very profound.
And I think, again, dentistry is so cheap. It's not
When
really
dentistry
valued.
is cheap
yeah,
and
when
free.
anything's cheap and free, you don't really value it. You
And-
can always get it fixed. It's not a problem.
And why, and the same thing with the exploding cost of healthcare. They look at the United States, things like, $700-800 million
Sure.
might be just duplicate bailing.
Yeah.
But no one even looks at their bill, because for Medicaid and Medicare, they won't even have like a 5% copayment.
Yeah. So
And I always thought to myself, if the United States had a 5% copayment on everything across the board, like talk about a 50,000 need
Yeah.
deal. Well, if say it was 10%, say a $50,000 deal and your portion was 5,000 or at 5%, $2,500.
Sure.
Do you know how many people would say, "Nah, I'm going to go exercise.
Yeah.
I'm going to go lose 50 pounds."
Well, that's interesting because certainly I've noticed in Asia, and not just in Singapore, but throughout Asia, health is much more important. Especially as you get older. I see many more people here in the evenings. If you walk around, you see a lot of older generation in parks doing Tai Chi, exercises, that kind of thing. People here can't really afford to get ill, in a big way. So you try not to. So prevention there is important, and health is a big thing. It's a big business here. A lot of companies are set up to make sure that you don't fall ill. So you look at nutrition, you look at diet, you look at exercise. A lot of things that we don't. Well, in some ways we do. There's we get it rammed down our throat in the West, but we don't do it. Here, people do it because they sort of have to. You can't really afford to get severely ill here.
Every engineer will tell you that everything has a trade-off.
Yep.
And what you said earlier is that when a government subsidizes anything, it gets more of it.
Sure.
And if you tax, and if you don't subsidize it and you tax it, you'll get less of it.
Absolutely.
So you're saying, okay, you subsidize dental insurance, so that's a good thing, but the trade-off could be that your personal behavior changes because the government's going to do it free. I always thought the smoking thing was crazy because they'll buy a $7, $8, $9 pack of cigarettes every day. But then when they get the $100,000 bypass, they expect, Obama or their employer to pay for it. And it's like, well, if you paid $7, $8 a day, shouldn't like $1 of that go into a fund? And they say, oh yeah, we've been waiting for you. You've been smoking for 40 years, and you have $100,000 put away, and we're ready to fillet you open.
It makes sense, but common sense is sometimes lost, I think, on the
common sense is not common. So if you have that whole university on CFAST, CFAST.com or
so CFAStresults.com.
CFAStresults.com.
And
then you have the
so
CFAST University.
Yeah, so once you get accredited with our system, we give you access to all that kind of stuff.
Mm-hmm. So what would be the next step for one of my listeners? What if someone wanted to do?
So we run courses.
CFAST?
We run courses throughout the US, and certainly in your show notes we can put up a link to where they can get more information on
And your main lecturer in the United States is Mike
so Mike
Miyazaki.
So I think a lot of your listeners will probably know of Mike, Dr. Mike, ex-LVI.
He taught at LVI.
Yeah, ex-LVI, so really seasoned lecturer, great
His father
guy.
is big in Sacramento and the
so he's second
CDA California
yeah,
Dental.
That's right. I think he's second or third generation dentist. Got a great practice in Sacramento. Great dentist and great educator.
Mm-hmm. So Mike is your main educator in the United States.
Yes.
And so what else do they need to know? Anything else you want to cover?
No, that's it in a nutshell. Certainly, if anyone's interested in looking at developing a CFAST type practice or introducing CFAST into their practice, then follow the show notes at the end. We can send them links. We can send them a whole bunch of information on how to get on a course and how to start using the system.
All right. Well, so do you think there's a fourth country in your view someday?
Sorry, say that again.
You think there might be a fourth country? Do you think Singapore is just the third?
I'm sure we're venturing that way.
Really? What would be your fourth country?
Well, so we've done a lot of Asia, but I'd love to be able to do something in China.
Yeah. So tell me why. You mean to live in China or to
No.
get CFAST in China?
To get CFAST in China. Living in China, I'd have to convince my wife. I think it's maybe a bit too far, but I would love to spend some time in China.
Have you spent much time in China?
No, I've only been there a couple of times.
I got in so far in China one time that the dentist I was with, he kept laughing because everyone would stop and just stare at me. and then I finally got to this area and I sat down on the floor, and it was a little grade school.
Yeah.
and these I remember this chunky little Chinese kid, and he couldn't have been 3 feet tall, and
Yeah.
they just kept getting closer and closer and closer, and finally he reached out and he touched top of my head. And he goes, "Oh," and I didn't move. I just smiled at him, so everybody knew it was safe. The next thing I know, there's
Yeah.
like 20 Chinese little kids
super.
all rubbing the top of my head. But back window, one thing you're saying, some people say a constrictive turtleneck with Asian gum disease. Some people say they have thinner gums. The smoking rate has got to have some factor, because I'm looking at the United States data that says 1950 half of adults smoked a pack a day. In 2015 it was under 18%, so it's gone from 50% to under 20%. I see a lot of studies showing that smoking rates in like Malaysia or Indonesia for adult males 40 can be 80 to 90%.
Absolutely.
Females as high as 30%. Do you think it's smoking, or do you think there's something we don't even know?
No, it's got to be a contributing factor. Smoking, without a doubt, definitely is a contributing factor here. But from the patients that I see, and I see patients who smoke and who don't smoke, there's still this underlying propensity to have gum
And
disease more so than less.
do you think we know what it is, or
I don't know. I mean,
is there anything combating it?
It's out with my skill to give you that answer. Certainly for what I can do on a practical level, and this is where something I do a lot more now with CFAS, is especially with lower incisors, just to be able to relieve that crowding, to make it easier for them to manage their oral hygiene. That I can show you a ton of slides where we've done that, and
It makes common
it
sense.
makes such a big difference to the health of the teeth.
And another thing that makes common sense is a lot of the mouthwashes, whether it be the chlorine dioxides like
Sure.
swimming pool water, or the alcohol base like Listerine.
Yep.
The chlorhexidine gluconate is a sticky oil, and when you look at the research
Yep.
junkies, they always point back that chlorhexidine gluconate is still better, and they think it's just because that sticky oil is killing bacteria for a long time after the chlorine dioxide or the alcohol based is gone.
Absolutely. Agreed.
Agreed.
Yeah.
All right. Well, you're an amazing man, buddy.
Pleasure, Howard.
And,
I've been listening to your podcasts for some time. It's great to finally be on one.
Is that right? Well, since you're Scottish, I'm going to have to charge you a penny.
A penny.
I know
I
that'll-
don't think I've got some wire. I've got some copper wire here. Would that do?
We'll smash the wire together. We'll make a penny.
Quite right. Quite right.
Okay. Well, thanks for coming.
Thanks for coming to Singapore.
Oh, it's an honor to be in Singapore. Ryan, thanks for coming with me all
Right.
the way to Singapore.
Pleasure.
Okay. Thank you.